Calf pain, it points more towards thiamine. Then ophthalmoplegia and foot drop, both of them again because of global confusion, ophthalmoplegia, ataxia, thiamine deficiency. Paresthesia is in the lower limbs, vitamin B1, B12, as well as biotin. So depressed vibration position sense indicates vitamin B12 deficiency. Forgetfulness, apathy, anxiety, depression, hallucinations. It also points towards niacin. This is how it begins with anxiety, depression, hallucinations, forgetfulness, and apathy. Gradually, it goes on to skin changes, the dermatitis, dementia, diarrhea, and death. Memory disturbances, you can begin with even in vitamin B1 deficiency, but in vitamin B12, you must have heard, it's a cause of reversible dementia. So memory disturbances. Hyporeflexia, loss of lower extremity DTR because of thiamine and vitamin B12. Conduct a formal cognitive and a depression assessment as appropriate. So dementia and depression, they are common causes of malnutrition, especially among the old-aged. The Wernicke's encephalopathy, it may be observed in severe thiamine deficiency, and Korsakoff psychosis, where you have confabulation as well. Now, how do you assess? So body composition and lab, these are the different methods. How I commonly remember them is ABCD. Anthropometrics or air plethysmography. B is bioelectrical impedance. C is with the CT scan or an MRI scan. D is with DEXA scan. Okay. And last would be water displacement and whole body counting and isotope dilution techniques. So anthropometry, if you know what is it, it's only by the mid-arm circumference, you have calipers. All of this, they require some training for reliability, but most important is you have to assess the muscle mass as well as subcutaneous fat differentially. Okay. Then bioelectrical impedance. Impedance means what? Resistance. So depending on the different resistance of the body tissues, you are assessing this. And water displacement, whole body counting, but all of this has only been limited to research settings and not been actually taken out in the domain. So DEXA is something which you can definitely adhere to. Okay, DEXA actually gives you the assessment of muscle mass, how much of fat is present. So when you know the patient is obese, obviously his fat will be more, but you may be missing out on the muscle mass. So that is what DEXA helps to find out. Okay. Then when you talk about CT, you should also talk about MRI. So that helps to find that, in fact, is a very good indicator of sarcopenia. So ABCD, just remember that this is bioelectrical impedance. And you have an indirect calorimetry. So indirect calorimetry helps you to find out what is your metabolism of your body, what is the resting energy expenditure. So resting energy expenditure is usually about 75% of total energy expenditure. We'll be coming to that in some time. So indirect calorimetry is another method how you can find out what is the metabolism of a patient. Now, those are the general examination. What about the lab investigation? So lab, when you think of, what all you think? First, a complete hemogram. So a complete hemogram, what are the things which you expect? CBC and total leukocyte count. Here you might have, leukocytosis in the presence of inflammation or even leukopenia, depending on if there is or no inflammation. Then your basic metabolic profile, which includes your liver function test, your kidney function test, albumin, your cholesterol as well. So when you have a low albumin, one thing what we have to think of is not just a protein loss, it's also a negative phase reactant. So albumin, it has a half-life of 14 to 21 days. Whereas pre-albumin has a half-life of shorter, that is about 2 to 3 days. It's a significant indicator of if there is a chronic inflammation happening. Okay, so it is actually a negative phase reactant. CRP is a positive phase reactant, whereas albumin and pre-albumin, they're negative. Retinol binding protein, it is synthesized from the kidney, and hence it is an assessment of the kidney function as well. Then LFT, PTINR, ECG, and this is indirect calorimetry, which helps you to find out what is the metabolism. Some non-specific indicators here are glucose, hyperglycemia, and total leukocyte count. Okay. So when you talk about inflammation, negative and positive acute phase reactants are there. You have albumin, you have pre-albumin, which are negative phase reactants. You have CRP, which is a positive acute phase reactant, and hence that increases. You have the non-specific ones with the total leukocyte count and glucose. So this is very non-specific. Other methods, how do you find out, is indirect calorimetry. So these are the ones which your textbook particularly talks about. Okay. Then you have certain ones like urinary urea nitrogen. That means ammonia or protein, okay, now protein which is lost in the body, that is what nitrogen is present. That is what the indicator of how much of protein is present, broken down, or how much of protein undergoes catabolism. That is mainly in terms of urine, urea, nitrogen, ammonia, which you can assess. Okay, so by assessing the urinary urea nitrogen, that you can find out how much of nitrogen balance is present in our body. Now, urine 3-methylhistidine shows how much of protein has been, this is again an essential amino acid, right? So, yeah, it's an amino acid. So, how much of protein is being lost? Okay, but it's not very specific. However, these are just for research purposes. This is how indirect calorimetry, which helps to estimate what is your resting energy expenditure. Now you assess who all are malnourished. Then you have to screen them, and you have to you have to optimize your treatment accordingly. So specialized nutritional support, which means you're specially giving a nutrition to the patient, which can either be optimizing the voluntary support, you're giving a special care to the patient, or otherwise you are giving a tubal feeding. So tubal feeding means what? It can go either into the stomach, like the nasogastric tube, or it could be a nasojejunal tube where it goes deep into the jejunum. Okay, and you have the parenteral nutrition as well. So parenteral nutrition is if you have IV, which is given everything intravenously, it is given. So the bioavailability is about 100%. So whatever the patient takes directly enters into the bloodstream itself. These are the three types of specialized nutrition. One is optimize the voluntary nutritional support. That means whatever the barriers the patient is having, what you're trying to overcome that. But for that, that is just between the food and until the time it is taken down. So once it goes down, then it's your body which should take care of it. So unless your body is in good control, you cannot optimize your voluntary nutritional support. You need a good stomach. You need a good intestinal peristalsis. There should be no inflammation. There should be no mechanical, mesenteric ischemia, any mechanical obstruction, perforation, peritonitis. So absorption and digestion should be good. So it's only in a lot of higher functions that have been involved. So these patients, who are the patients who definitely benefit from optimizing the nutritional support? They are the patients who have usually not cared for. They don't get the food which they have, what they like. They're choosy about food, or they don't like the food, the way it has been prepared, the way it has been presented. The swallowing part, the ill-fitting denture is what we talked about. They are having, now a difficulty in swallowing. They could be because of old age itself, or it could be because of some nutritional, deficiency, the neurological condition, which is stopping them from taking it inside. So here you prepare it in a way that they can overcome this barrier and take it inside. But once it's taken inside, then the body should be able to take care of it. Yeah. So enteral nutrition is when you are enteral, which means what? Directly into the intestine or the gut. Delivers new liquid formula through the Ryle's tube. So you have nasogastric, which is through the stomach, and you have the nasojejunal, which is directly into the intestine. So what's the essential difference out here? You are bypassing the second part of the duodenum, small intestine. Okay, so you're going into the jejunum. So why is the second part of the duodenum very important anatomically? Because that is where your ampulla of Vater is present. So your CBD and your pancreatic duct, they join, they form a common bile duct, which enters into the second part of the duodenum. So where do you actually find nasojejunal feeding more important? When a patient with pancreatitis. So in a patient with pancreatitis, what happens? You want to give rest to the pancreas. How do you treat pancreatitis? Just by giving some rest, which means whenever you eat anything, be it carbohydrates or fats or proteins, your pancreas contracts. It actively secretes the pancreatic juice. So in a patient with pancreatitis, when you want to give some rest, you want to make sure they're not, the pancreas is not stimulated. And that stimulation comes when the food is in the proximal small bowel. So what you do, you enter a tube into the distal small bowel so that you're giving sufficient rest to the pancreas. Parenteral nutrition, that's the last part. Okay, and so when to use specialized nutrition support, nutritional disorders requiring intervention to restore or maintain the nutritional status. So it's based on screening and assessment of severity, clinical context, and urgency. It involves determining modality, composition, and method of administration. So it requires a close collaboration between physicians, clinicians, dietitians. So nutritional physiology. So this is what we have to know. A healthy sedentary adult, commonly, this is the total energy expenditure. This is the average energy expenditure for the Western population. Okay, what they give. in the textbooks. 36 kilocalories per kg per day. And resting energy expenditure should be at least 75% of this. So when does the resting energy expenditure increase? It increases during acute illness or fever. Whereas in starvation, your body adapts to this and hence it is reduced. Energy requirements may be less during energy intolerance or greater during recovery, which means when you're trying to recover from an illness or an injury, okay, like for example, a severe sepsis or fever, or you had an injury, you had a surgery, and you're trying to recover from that, there you require additional energy. So what about protein and amino acids? So proteins, minimum daily intake should always be at least 0.8 gram per kg per day. This is the recommended daily intake. Minimum is 0.65 gram per kg, but 0.8 to 1.2 would be a recommended daily allowance of protein. And protein loss, what are the conditions where you have protein loss? Whenever you have a protein loss, you should compensatorily increase the intake. So protein loss usually occurs either through the gut, which means through inflammatory conditions like diarrhea, or it could be through the skin, like through fistulae or through exudates. From your kidney, the patient has got any chronic kidney disease, there also there will be protein loss. So in any of these conditions, when there is increased protein loss, you have to encourage more protein intake. High protein catabolism, like in glucocorticoid therapy, and systemic inflammation as well. So patients may lose up to, so in acute critical illness, about 15 grams of nitrogen per day is what is lost. 1 gram of nitrogen loss corresponds to about 6.4 grams of protein. So when you have 15 grams of nitrogen loss, it corresponds to about 94 grams of protein. Okay. So recommended daily allowance in such critical illness is always on the higher side. So when you talk about 0.8 to 1.2 is normal. In a condition like this, when there's an acute illness, you have to increase the protein intake to as high as 1.5 gram protein per kg per day. Then we spoke about energy and we spoke about protein. Now, energy deficiency and systemic inflammation. So this increases your protein requirements. Okay, so minimum energy provision is how much? At least 50% of total energy expenditure, which means if you're taking 36 kilocalories as an adult per kg per day, at least 50% of this has to be supplied. If you don't supply even this 50% of this 36 kilocalories per kg, then what happens is there'll be some amount of, the beneficial effect of protein, what you give will actually be lost. So that's what they say. A hypocaloric nutrition, energy intake below total energy expenditure with a compensatory protein increase. That is hypocaloric nutrition. Whereas what is the minimum energy? At least 50% of the total energy should be given to the patient so that the beneficial effect of protein is not lost. Okay? Otherwise, what will happen if you take less than 50%? Whatever protein you're giving, that will also be used up to the systemic inflammation. Now, that's about energy as well as protein. That is your major. Then you have your micronutrients. Micronutrients are your vitamins, your minerals, the electrolytes. So the water soluble as well as the fat soluble vitamins, minerals, essential fatty acids, and trace elements. Trace elements would mean your copper, your magnesium, cobalt. Okay. And deficiencies, you can also expect sodium, potassium, magnesium, and phosphorus, which are very common in hospitalized patients. That's where whenever you run the electrolytes, you have to do the sodium, potassium, okay, it comes in your renal pack. Phosphorus and magnesium also has to be covered. Subclinical deficiencies like zinc, vitamin C, vitamin D, these are also often overlooked. So this also has to be taken into consideration. So it's not only the energy, it's not only the protein, even the micronutrient. So what are the malnutrition syndromes? So 3 things we learned. One is because of starvation. The other one because of disease. So in disease also, again, you have acute and chronic disease. Okay, so starvation related is prolonged semi-starvation results in muscle atrophy, skin thinning, lethargy, and functional disability. So prolonged semi-starvation results in starvation. So there is a loss of protein, there's a loss of fat. There is when you have a loss of protein, when you have loss of fat, what happens is a functional disability also plus, but there is a compensatory increase in water fluid. So you can have a 20% increase in the ECF volume. Manifestations will be fat as well as muscle. Both are lost, but weight loss is always present, can be masked sometimes if there is a starvation edema. What are the causes for this? It's either because of food deprivation, anorexia, dysphagia, mechanical obstruction, poorly presented food, or any of this. So if you just take a person who has been ignored or neglected for a very long time, okay, so a person on the road, Like you can know this thing, you can almost imagine. They have been deprived of food. They don't have access to it. They have anorexia there also. Dysphagia, difficulty in swallowing, if at all is present, mechanical obstruction, poorly presented, or any of this. They would be fitting into this. But chronic disease related means what? They're having some chronic disease underlying. Associated with that, some amount of inflammation may also be present. So starvation, which is complicated on a chronic systemic inflammation. So chronic infections, autoimmune, severe hepatic, renal, kidney, malignancy, everything you rule out. Okay, these are the common causes. Characteristics, again, just similar to that. A patient who has got a chronic autoimmune disease, you can imagine, they'll have, why would they be thin? One is because of anorexia, decreased protein intake. Next is because of increased muscle catabolism. Muscle atrophy happens and vicious cycle of worsening disease. So management is, you have to treat the underlying chronic ailment as well. Plus you have to give nutrition supplement also. So in starvation, it's only nutrition. There is no chronic disease. Whereas in a patient with CDM, chronic disease related malnutrition, there is a starvation and there is an infectious component. So you have to, or you have a disease. So starvation has to be addressed by nutrition, and the underlying infection or the inflammation should also be controlled. Cachexia is an older term which is synonymous with severe chronic disease malnutrition. That is, the patient, when you say a patient is cachexic looking, that is when they have an underlying chronic disease and they have a systemic inflammation also causing the muscle dystrophy, loss of muscle mass, all this. So there is starvation with a superimposed inflammation as well. It could either be because of tuberculosis, it could be because of malignancy, it could be because of HIV, anything. Whereas acute disease-related malnutrition is when you have an acute injury, either in the form of an illness, or it could be a sepsis acute, or it could be because of any surgery as well. So any acute condition which is causing this. There also, there will be muscle atrophy, there will be disuse of muscle may not be there because it's an acute condition, but muscle atrophy will be there if the patient is not receiving enough protein. But what's difference is you have an increased resting energy expenditure because the body tries to compensate. Okay, and the muscle mass which is lost is about 3 to 5 times faster than in simple starvation. So death occurs more rapidly in acute if the patient is not being provided adequate nutrition promptly. Okay, so how do you make a diagnosis of this? Key features of SRM and CDM would be muscle atrophy, subcutaneous mass, the BMI, visual BMI, all of this. So muscle atrophy, generalized muscle atrophy and diminished body fat mass, both muscle as well as fat. So when you look at a patient itself, they'll be very poorly nourished. You can see the skinny thin folds. If you examine the subcutaneous fat may be less. You examine the muscles, the muscle mass will be less. There will be disuse atrophy. And muscle mass is easily observed. Causes of muscle mass in such patients, again, especially with patients who have a chronic disease related is what all. In starvation, it could be because of muscle atrophy as well as because of not using it. Atrophy and sarcopenia, decrease in muscle mass. Whereas in a patient with CDM, chronic disease related, there will be an acute inflammation which is going on. And you'll have a high dose glucocorticoid for endocrine lesions if given, or a primary muscle or a neuromuscular disorders. Like for example, you take a case of Parkinson's. Okay, the primary muscle disorder or a neuromuscular disorder also, they will have myasthenia. So these are conditions where they'll have an increased weight loss. SRM and CDM are common contributors to muscle atrophy. Then subcutaneous fat. So when fat is lost, severe depletion indicates starvation, but it's not always present. Whenever you have a patient with obesity, you will have fat as well as protein loss, but protein loss will be very obvious. So these patients may still have SRM, starvation, or CDM despite residual subcutaneous fat. So ECF volume, in starvation, what happens is an increase in ECF volume, which contributes to the edema. Whereas in chronic disease related, it's a hypoalbuminemia, which causes edema. Then body mass index, like, body mass index, 19 to 20 is just reduced body muscle mass. Less than 15 is severe starvation. Less than 13 is almost incompatible with life. Is more than 17 doesn't exclude starvation, obese, or edematous patients. So it's more than 17 also. Still, what is important is what is the proportion of your protein and that is your muscle and fat. So muscle and fat is what we have to see. Visual BMI. Some clinicians, they can estimate BMI just by assessing the patient. You look at them, they can say what could be the possible BMI in non-obese or non-edematous patients. But if you extrapolate this even in edematous and in obese patients, they'll be able to figure out. So that's actually quite a talent to know. Okay, it's a skill to learn, to be learned. And that is on examination. Lab investigation, we learned about muscle mass. Ultrasound specifies but would not complement physical examination. Systemic inflammatory markers like CRP, total leukocyte count, albumin is low, pre-albumin is low. It contributes more towards inflammation. Protein catabolic intensity. Okay, so that is depending on your urinary nitrogen loss, which comes in urinary urea nitrogen, or you have your ammonium. These are the different forms in which, but urinary urea nitrogen, this is the commonest way how you can assess. Okay, so it may, and your nitrogen balance, that would be even negative in severe acute inflammatory conditions, which means large amount of catabolism is happening. The urinary urea nitrogen is quite high. So specialized nutritionist support mainly consists of three types. We learned one is optimizing the voluntary support, one is enteral, and one is parenteral. So what are the indications? Preferred approach always in optimizing the nutritional support is always the preferred approach. Okay, because this is what actually empowers the patient. You're giving the patient the confidence that, see, you can eat well if the food is being prepared like this and given properly. So it's a patient-centric approach. Limitations are, it can be time-consuming. It can be very labor-intensive. You have to actually teach the patient or teach the caregivers. Look at the financial constraints, everything. What is pleasing the patient to have more food? But that is more promising. Whereas enteral nutrition, it's not a complete, it doesn't just end by itself. From enteral nutrition, you have to switch to optimized nutritional support. So it's almost like a step-up therapy. So if you have enteral today also, you have to motivate the patient for optimized nutritional support later on, right? So if the patient is having a parenteral nutrition, initially you have to go towards enteral, and from there you have to empower the patient. So enterally you're delivering it, but it requires a normal GI tract, which means you can just give the food until it reaches the stomach or the jejunum. Thereafter, the maldigestion and malabsorption, that has to be taken care by the body. So it maintains the digestive and absorptive and immunological function of the GIT. That's more important. Safe, effective, and it's a very simple method. So this is a PEG tube. This is an intragastric, and this, is from the jejunum. So these are the different forms. Enteral nutrition, you have the different, what can be given. The standard polymeric, which means carbohydrates, proteins, and fats. You're giving them. That is the standard one, which contains about 1,000 to 2,000 kilocalories per day and 50 to 70 grams of protein per day. That is, all the proteins, essential, non-essential, all of the amino acids are given properly, but it requires, you can supply everything, but your digestion and your absorption. So who digests? It's your pancreatic mainly. So there should be no maldigestion or malabsorption. All that you can do is just provide all the macronutrients. Then polymeric formula with fiber, which means there is polymeric plus fiber also. So fiber itself, you have two types. You have soluble fiber as well as insoluble fiber. So soluble fiber reduces the bloating, whereas insoluble fiber is what causes more of bloating. But what it actually helps is fiber reduces the orocecal transit time, which means from the time from which the food has been taken to the time it exits, the time has been reduced, which means what? It helps in peristalsis better. It helps in pushing the food forward. So the more the time the stool or the food, the chyme stays inside, there'll be more absorption. So soluble fiber, so for fiber, what it does is it actually reduces the time the stool will be there in the colon. Okay, so if the stool is there for a very long time in the colon, there's a lot of water which is being absorbed and becomes very dry, ending up in constipation. So that is prevented by fiber. Fiber also firms up the stools. Similarly, soluble fiber, what happens? It forms, we have learned when we learned about absorption. Soluble fiber, probably like agar and pectin, which has not been absorbed in the body, they become short-chain fatty acids. And the short-chain fatty acid is an important source of nutrition for your colonocytes. Okay, so nutrients for your colonocytes, which is also provided and reduces the orocecal transit. Then elemental and semi-elemental formulas. Out here, macronutrients are hydrolyzed and they're designed for patients who've got malabsorption or prolonged bowel rest. Immunity enhancing, that is to enhance immunity. Protein enriching ones, 90 grams of protein and 1,000 kilocalories. So calorie is almost the same, but instead of 50 to 70 grams of protein, you're giving more protein. In immune enhancing, you're giving more amino acids, you're giving omega-3 fatty acids, glutamine, and antioxidants, which alters immune response. So this you just have to learn by heart. You have the standard polymeric, the polymeric with more fiber, the polymeric with more protein, polymeric which is immune enhancing, and the semi-elemental and the element. These are the 5 types. So what are the diseases? Depending on what the patient is having, you should give. It's tailored to the conditions like diabetes, hepatic, renal, or pulmonary, and may improve the metabolic outcome, but it lacks definitive clinical outcome evidence. So this is just a small case, Vignant, a 48-year-old woman with severe stroke and dysphagia. Started on NG feed, taking a polymeric diet. So you started a standard polymeric, but after 24 hours, she develops abdominal distension and gastric aspiratus 450 ml, which means what? What is the diagnosis? She's having abdominal distension. So once you give the food also, it's not just, going down, there is distension. GO or a gastroparesis, you can see. Okay, so you can see a gastroparesis. Yeah, that's also a GO only. Very good. Gastric outlet obstruction or even a gastroparesis. Okay, so gastroparesis means there is no proper obstruction. It's only the contractility which is abnormal. Gastric outlet obstruction is when they actually have an obstruction which is preventing the food from going down. Okay, so gastroparesis probably is present. Why is this gastroparesis or a delayed emptying? It can be due to intolerance towards the enteral feed. So what do you do for such patients? Just slow down the way you give food. Okay, so you temporarily withhold, wait for the abdominal distension, but slowly, come back to normal. Assess the electrolytes. When the patient is having hypokalemia, hypomagnesemia, hyponatremia, they will have a decrease in the peristalsis. Then you elevate the head end of the bed to at least 30 degrees and consider post-pyloric feeding, which means that's the last thing. So post-pyloric feeding means beyond the pylorus you go and you insert the Ryle's tube in the jejunum. So these are the different methods because you think now the food is stagnating in the stomach. There is small tardy stomach. So assess what is the cause of it. One, it could be because of diabetes. It could be because of hypothyroidism. There is a slowness. Dyslipidemia can cause. Still, it's not. Raise the head end of the bed or promote a post-pyloric feeding.